So, very good morning to all of you. Today we will deal with the clinical enzymology. As in the diagnosis of diseases, we have to do a lot of clinical tests, and among them, the estimation of enzyme activity, which are mainly related with the metabolism. If we estimate the activity of these enzymes in the blood or plasma, we can reach up to a diagnosis or prognosis of a disease. So the study of the clinical enzymology is particularly important for diagnosing the diseases. So, because in the blood plasma there are certain enzymes which are not normally present. These are the non-specific or non-functional plasma enzymes. But apart from them, the certain enzymes or certain enzyme-like molecules they may all present in the plasma, and they are the plasma-specific enzymes. So, why we have to need the study of clinical enzymology? Because the small amounts of intracellular enzymes, it is always present in the blood as a result of normal cell turnover. Because due to the apoptosis or regular cell death, the contents of the cytoplasm or the cytosol, they come out into the extracellular fluid or in the blood. So, a small amount of the activity of these cellular enzymes, it is always present in the blood. But when the cells get damaged, or because of some neoplasia or cancers or neoplasm, the cell mass get increases, and due to that also the content of the cells it comes out, and the activity of these non-specific enzymes, non-specific plasma enzymes get increased. So when damages to cell occur, an increase in the amount of enzyme will be released and their concentration in the blood will get to rise. And particularly in these conditions, when the cells get damaged or cell mass get increased, means when the plasma enzyme activity, non-specific plasma enzyme activity is increased, these enzymes can act as the diagnostic marker of underlying disease. Means there are the certain enzymes which are organ specific. So if we estimate the activity of that particular enzyme and we get a high activity of that enzyme, then we can reach to the organ that yes, there is a damage of that particular organ. Because of that, the enzymes activity in the plasma get increased. So enzymes can also act as the reagent for various biochemical estimation and detection, and it helps in the ascertaining the response to drug in a disease. Say, for example, if you diagnose a disease and you treat that disease with a particular drug, and after 7 days or 10 days, you again estimate the level of activity of that particular enzyme again, and if you get a decrease in that activity, means your treatment is going in a right direction. So you can prognose the disease, and or you can adjust your treatment by analyzing the enzymes in the plasma. And it also helps in ascertaining the time course of the disease, because in certain diseases, uh, at particular time interval a particular type of enzyme activity will be increased. Say, for example, in the myocardial infarction, there are two or three enzymes which are released sequentially. First is the creatinine phosphokinase or the SGOT. SGOT is released a little late, whereas the creatinine kinase released that earlier. So in the acute condition, or when the patient has an acute myocarditis or myocardial infarction, and you estimate the this creatinine kinase, you will get a high. And if a patient, you are supposing that yes, there may be a myocardial infarction, and you estimate the creatinine kinase, the creatinine kinase activity may be at basal level. If the patient is come to you little late, means after 3 or 4 days, if the patient reach to you, the creatinine kinase activity will not be at higher side. It will be at basal level or normal level, but the SGOT concentration will be higher. So by doing the multiple enzyme analysis, you can ascertain the time course of a particular disease. But however, such increase are not always due to the tissue damage. Means if you are getting a higher concentration, higher activity of these enzymes in the blood or plasma, always it will not correlated with the disease of any particular organ. But the increase may be because of the increased cell turnover, because of more cell death or more apoptosis due to some drug treatment, or due to the cellular proliferation, or maybe due to the increased enzyme synthesis, because of certain medications, because of certain xenobiotics, the enzyme is induced, the genes get induced, and the synthesis of these enzymes is increased, and they come out into the cytoplasm. And one more possibility maybe there is the obstruction to the secretion of these enzymes. So apart from the damage, these are the few other factors. Because of these factors, the activity of enzyme may be increased in the blood plasma. So the measurement of the activity of enzyme in the serum or plasma are of value in the diagnosis and management of wide variety of diseases. Almost in the every disease or every patient, we go for the liver profile or the kidney profile test. And in the liver profile test, we do the multiple enzyme analysis like the SGOT, SGPT, ALP, or the GGT. These are the routine enzyme estimation which we do in our patients. If we are getting a clue that there is involvement of the liver. So in the enzymes, there are various isozymes also. Now, what are the isozymes? As in the enzyme classes, we know in the detail about the isozymes. These isozymes, they catalyze the same reaction, but they differ in the amino acid sequence. And because of the change in the primary structure, the physical and the chemical properties may be different for the isoforms of the enzymes. And they are separated on the basis of their charges. Because the primary structure is different, so the overall charge over the enzyme molecule, enzyme isoforms, they may different. And these isozymes, they are tissue specific. Means one type of isozyme is present in a X organ, and B type of isozyme is present in a Y organ. But they always related with these organs. The B isozyme will not present in the X organ, or the A isozyme will not present in the Y organ. So on the basis of the estimation of these isozymes, we can locate the particular site or particular tissue, because they are tissue specific. And different isozymes may arise from the different tissues, and their specific detection may give clues to the site of pathology. Now how we measure the enzymes. In the enzyme classes, we had told you that for the estimation of enzyme, we never use the concentration of the enzyme. We always estimate, or we always measure the activity of the enzyme. So for the measurement of enzyme activity, there are two type of assay. One is the endpoint assay, and other is the kinetic assay. In the endpoint assay, means at a particular time, incubation time, we stop the reaction, and after stopping the reaction, we measure the amount of optical density, amount of chromosome present in the test tube. So such assays which are performing after stopping the reaction, these type of assay are generally the endpoint assay. And for the kinetic assay, with the we note the optical density at regular interval, and then we take either the difference of the optical density and we divide it with the time. So actually we measure the change in the optical density per unit time. So after 3 or 4 minutes incubation, we measure the optical density at regular interval and do the mathematical calculation. So in the kinetic assay, we actually not stop the reaction, but the reaction is continuously going on till the substrate is present. So these two type of assay generally used in the clinical biochemistry. One is the endpoint assay and the kinetic assay. So these two assay also available for the enzyme estimations. So the measurement of enzyme, they may be affected by the either the presence of the inhibitors or the activators in the solution in the blood. Hence, most of the enzymes they are measured by coupled assay. Coupled assay means this is our target enzyme, and we provide the substrate of the particular target enzyme, and this substrate is converted into a certain product. Then we do a next chemical reaction, next enzyme catalyzed reaction of that product, and this conversion into a second product, and this reaction we actually measure. Here we are not directly measuring the GPT concentration. Actually, we measure in the instrument the utilization of this NADH2. So if there is higher utilization of NADH2, it correspondingly relate with the higher activity of GPT. Means as much as of pyruvic acid is synthesized, there is a increased utilization of this NADH, and there is a difference in the optical density because of this linked enzyme reaction. So by noting the optical density change by the utilization of this NADH2, we ultimately estimating the activity of this GPT enzyme or the target enzyme. So the most of the kinetic enzymatic assay, they are the coupled assay. So a coupled assay is one in which a second enzyme is used to act on the product of enzyme of primary interest. Second enzyme generally use the NADH as a coenzyme, and the rate can be followed by measuring the oxidation of NADH, and this optical density we measure at 314 nanometers generally. So these enzymes are also used as a diagnostic marker because the enzymes which are present in the plasma, they are categorized in two types. One are the functional plasma enzymes. Means these type of enzyme are always present in the plasma in higher concentration. So certain enzymes, proenzymes, or the substrate, they are present at all time in the circulation of normal individual and perform a physiological function in the blood, like the lipases, pseudocholinesterases, or the proenzymes for the blood coagulation. So to use these enzymes as a diagnostic marker, if there is any decrease in the activity of these plasma specific enzymes, will correlate related pathology. So if means if enzyme is present in higher concentration normally, then if there is any decrease in the activity of these plasma specific enzyme, we may reach to a particular disease diagnosis. Second type of enzymes which are present in the plasma, these are the non-functional plasma enzymes. Means at normal individual, in normal healthy individual, the activity of these non-specific plasma enzymes or non-functional plasma enzyme activity is present at very low amount. But if the activity of these plasma enzymes get increase in the blood, means there is the damage or the excessive growth of the tissue. So these non-functional plasma enzymes, they are cell-derived enzymes, and plasma also contains numerous other enzymes that performs no known physiological functions in the blood. And these apparently non-functional plasma enzymes, they arise from the routine normal destruction of erythrocyte, leukocytes, and the other cells. So if there is any damage or necrosis which results from the injury or the disease or the neoplasm, they generally accompanied by increase in the level of several non-functional enzymes. This is the normal cell turnover. So very small amount of non-functional, non-specific plasma enzymes, they get released and they present in the blood vessels. But when there is a neoplasm or the excessive cell growth or damage to a tissue, damage to a cell, then these cytosolic enzymes, they come out and they are present in the blood plasma at higher concentration. So there are various enzymes which are important and they are related with their organs like the SGOT or the AST, it is the same name. They are generally present in the heart and liver. ALT also present in the heart and liver. The GGT, it is present in the liver. The acid phosphatase, it is present in higher concentration in the prostate. The alpha amylase, it is present in the pancreas. So there are a lot of enzymes which are particularly present in certain organs. So if we get any increase in the activity of these specific enzymes in the plasma, we can reach to the organ like these. So if we get the increased activity in the acid phosphatase, then we will reach to the organ prostate. So there may be a prostatic carcinoma, which may be a cause
सर
to increase.
हिंदी में भी सर बता दीजिए.
अच्छा, ठीक है. कहाँ पहले का समझ में आया?
पहले का आ गया
एंजाइम्स पहले का आ गया ना. तो जितने भी एंजाइम्स हैं, हम एंजाइम्स का एस्टिमेशन क्यों कर रहे हैं? जनरली जो हमारे ब्लड में एंजाइम्स हैं प्लाज्मा में, वो दो टाइप के एंजाइम्स हैं. एक तो जो नॉर्मली प्रेजेंट हैं, जिनके फिजियोलॉजिकल फंक्शंस हैं, लाइक द सेरुलोप्लाज्मिन, लाइक द लाइपेजेस, लाइक द स्यूडोएसिटाइल कोलिनेस्टरेजेस, दे उनका कुछ कुछ फिजियोलॉजिकल फंक्शन है. जैसे सेरुलोप्लाज्मिन है वो कॉपर ट्रांसफर करता है, फेरिटीन है वो आयरन ट्रांसफर करता है. तो उनका एक So the first clinically important enzyme are the transaminases, and in this transaminase reaction enzymes, mainly the SGOT and SGPT or AST or ALT, these two enzymes we generally evaluate in our blood samples. So normally these two enzymes, they are present in the plasma, in the CSF, in the saliva. All these biological fluid we can use to evaluate the activities of these enzymes. Though the serum levels of both of these two hormones become elevated whenever disease processes affects liver cell integrity, but ALT is more specific towards the liver cells in respect to AST. AST is more relevant with the cardiac disease or the cardiac cells and the muscles, soft tissues. But ALT is more specific towards the liver. So after myocardial infarction, there will be an increase in AST, but not the ALT. But when the liver get involved or some hepatitis or cirrhosis condition is there, then the ALT concentration, ALT activity will be higher in the blood plasma. So first we will deal with the AST. This AST is present in high concentration in almost all of the cell, but these four type of cells they have the more concentration, like the cardiac or muscle cells, the liver, kidney, and the erythrocytes. Note here the AST concentration is higher in the erythrocytes as well. So if your blood sample is hemolyzed, even a traces of hemolysis occur in your blood sample, then this AST will release from these erythrocytes. And if you estimate the AST in the hemolyzed sample, you will get a higher activity of AST, which is not the actual AST activity. So be cautious during your evaluation for these enzymes, which are particularly present in the erythrocytes. So to estimate the enzymes, we generally prefer the non-hemolyzed plasma or serum samples. Actually, for all the biochemical examination, your sample should be non-hemolyzed. If there is hemolysis occur, then the contents of the erythrocytes, they come out in the plasma and give you erroneous readings, or the interpretation will be changed. So if there is any damage to any tissues among these, there will be an increase in the AST activity. So when we get a higher AST concentration or AST activity, there may be few reasons by which we are getting the higher AST activity. One is the artifactual, which is not because of any disease. It is because of our procedural faults. And among these, important is the hemolysis that we have discussed, that because of hemolysis, the AST which is present in the erythrocytes, it comes out. So this is not the actual AST level. It is the higher AST activity is because of the hemolysis. So this is considered as the artifactual. Other is the physiological. So during the neonatal period, when the individual is growing, so in the growing phase, the activity of the AST in the blood plasma, it is higher than the normal activity of the AST. And if there is any disease, any pathology occur with the listed organs, like the myocardial infarction, shock, the viral or toxic hepatitis after trauma or the surgery, or hemolytic episodes or hemolytic type of disease, like the autoimmune diseases. So in those autoimmune diseases, when there is excessive hemolysis occur, in those conditions, the AST activity in the blood plasma is we found as increased. So to evaluate the AST activity in the blood plasma, yesterday we had discussed about the coupled enzyme reaction to evaluate the enzyme activities. Similarly, yesterday we had dealt with the GPT activity and estimation. So the principle is same for the AST, but here we use the malate dehydrogenase enzyme instead of lactate dehydrogenase, because the product of the AST is the oxaloacetate. For the GPT, it is the pyruvate. So in the AST estimation, this oxaloacetate is converted into malate by this malate dehydrogenase, and the cofactor NADH2 it is utilized, and the optical density change in unit time we measure for the utilization of this NADH2. And among the estimation of these enzymes, blood non-specific plasma enzyme or non-functional plasma enzyme, one more thing we have to consider during our blood collection. For the enzymes, there are certain inhibitors or chelators may be present if we take the plasma. Like if you are taking the plasma, you are adding some EDTA or other chemical. If you are adding the chemicals instead of physiological anticoagulant, physiological anticoagulant is heparin. If you are taking the heparinized plasma, then you can get the actual enzymatic activity. But if you are using some chelators like EDTA, EDTA is a chelator which chelates the calcium and inhibit the coagulation process of the blood, collected blood. So because the calcium is removed from your blood sample, and if you take the plasma which is taken in the EDTA vial, then the calcium is removed, and there are the enzymes which may have the which may require the calcium as their cofactor. So there is no calcium, and if you are evaluating the activity of those enzymes which requires the calcium, so you will get a lower concentration or lower activity of those enzymes. So it is preferred that if you are doing the enzyme estimation in the blood, go with the serum, not with the plasma. Serum is the preferred biological sample to evaluate the enzyme activity. So question may be asked about this in your